It is just a huge honor for me today to be podcast interviewing Rear Admiral Timothy L. Ricks, D.M.D, M.P.H, F.I.C.D, currently serves as the 19th Chief Dental Officer of the United States Public Health Services, as well as the Assistant Surgeon General. He serves as the Surgeon General's spokesperson on oral health and interacts with chief dental officers from other countries, with military chief dental officers, with leaders in organized dentistry, with state oral health programs, and much more. He is currently overseeing the development of the second ever Surgeon General's Report on Oral Health. Rear Admiral Ricks has served in the U.S. Public Health Service for over 21 years. Prior to this service, he was an associate dentist, independent contractor, and sole proprietor. He has also served as a military police officer in the Army National Guard. If I read his resume, it would take the entire hour-long show, so I'm just going to leave it at that. Rear Admiral Ricks, thank you so much for coming on the show today to talk to our dentist. It's just, I can't tell you what an honor it is.
Well, thank you very much for having me today. I look forward to talking to everyone at Dental.
Well, my gosh, you're busier than a one-armed dentist, and so you have an amazing presentation. I've gone over it, so I'm just going to bow out and let you give your hour-long informative presentation, and then we'll talk at the end.
Thank you very much.
By the way, I love your accent. I grew up in Kansas, and I hear that little Mississippi, Tennessee sneaking out of there.
Yeah, that's true. And I'm actually talking to you today from Nashville, Tennessee, which is where one of my offices is. So again, thank you, Dr. Ferron and Dental Town for inviting me. And so what I'm going to do today is cover a lot of territory in about an hour. So I'll talk about access to care, COVID-19, the topic of the day, some issues affecting oral health, and the Surgeon General's report on oral health. This picture here is with me and some of the dental leaders of the past and present. So this is our current Surgeon General, Vice Admiral Jerome Adams. We have several former Chief Dental Officers, including Deshanka Kleinman, Bill Bailey, Bill Moss, Skip Collins, Bob Mecklenburg from the 1980s, Chris Halliday, Nick McCready's, and Steve Corbin. So those are some of the names that you may have heard in the past. So first of all, I have to say I have no disclosures regarding financial relationships, commercial interests, or funding from commercial support or external sources. And throughout this slide presentation, I've referenced sources for the information that I provide. Usually when I give these presentations, I always list learning objectives, things that you should be able to get from the presentation. Now I'll let you read these to yourself for a second. So what I'll do is I'll talk a little bit about the U.S. Public Health Service. Not everyone's familiar with the USPHS. I'll describe some oral health inequities that certain populations in the U.S. suffer from, including rural America. I'll list some of the barriers to access to care. I'll talk a little bit about COVID-19 and oral health. I'll also add some information about Healthy People 2030, the oral health objectives at least. And then I'll talk briefly about the Surgeon General's report on oral health, the second ever one that is forthcoming. So first, let me talk about the U.S. Public Health Service. Our motto is in the service of health, or in officio salutis. We are one of 8 uniformed services: Army, Air Force, Navy, Marines, U.S. Coast Guard, National Oceanic and Atmospheric Administration, and the new Space Corps, the other 7. Our history goes back to more than 200 years ago. And in fact, we started as a U.S. Marine Service, taking care of sailors from foreign ports and so forth. The U.S. Public Health Service is unlike the military in that we have no enlisted members. We're all officers, and we represent many different specialties, including physicians, dentists, nurses, pharmacists, and you can see the entire list there. We're led by the Assistant Secretary for Health, which is, if they are an officer, sometimes they are and sometimes they're not, that is a 4-star admin. And then our operations are led by the Surgeon General of the United States, the nation's doctor, who is usually a 3-star admiral. And again, our current Surgeon General is Vice Admiral Jerome Adams. Our primary mission is to serve underserved and vulnerable populations across the country. We provide essential health services and health support services to vulnerable populations, not just in the US, but abroad as well. And in fact, that picture on the right is from Africa in the Public Health Service response to the Ebola campaign. We also lead programs, do research, address and advance innovation in science. And we also respond to public health emergencies, including the COVID-19 pandemic, including Ebola, including hurricanes. We've had a lot of deployments in response to natural disasters like hurricanes in the past as well. You know, regarding dentists are actually in the U.S. Public Health Service are assigned to various different agencies in 3 different departments in the federal government. So within the Department of Justice, U.S. Public Health Service dentists staff the Federal Bureau of Prisons. Within the U.S. Department of Homeland Security, Public Health Service dentists serve the U.S. Coast Guard, as well as the Immigration and Customs Enforcement Health Service Corps. But primarily, our U.S. Public Health Service dentists serve within the Department of Health and Human Services in agencies such as the Center for Medicare and Medicaid Services, the Indian Health Service, the Food and Drug Administration, the Health Resources and Services Administration, Centers for Disease Control and Prevention, and the National Institute of Dental and Craniofacial Research, which is part of the National Institutes of Health. So, specifically, what do public health service dentists do? Again, we serve to vulnerable and underserved populations and provide direct clinical care to populations such as American Indians and Alaska Natives. That's through the Indian Health Service, to federal correctional inmates through the Federal Bureau of Prisons, to immigrants and detainees through the ICE Health Service Corps, to service members such as what we see in the U.S. Coast Guard, and to poor and underserved people across the country through community health centers that are funded by the Health Resources and Services Administration. We also manage population-based programs such as Medicaid, national surveillance efforts such as the National Health and Nutrition Examination Survey, provide infection control guidance primarily through the CDC, Division of Oral Health, and community water fluoridation also through CDC. And then HRSA also manages and oversees many different types of grant opportunities that have an oral health component. We also conduct research, and primarily our research agency is the National Institute of Dental and Craniofacial Research, or NIDCR. And then finally, we have some regulatory authority through agencies like the Food and Drug Administration. So if you're interested in learning more about the U.S. Public Health Service, or if you're considering a change in careers, here are 2 links that might help you. We have a listing of vacancies that is updated each month across all of our agencies, as well as application materials online as well. So now I want to switch gears and talk about oral health inequities. One of the things that we see in the United States is that less than half of Americans are able to access dental services each year. And in fact, Healthy People 2020, Healthy People was a set of national objectives that has been set for 50 years for each decade. And the Healthy People objectives that were set in 2020, one of them was to improve access to care to where almost half, 49% of Americans are able to access care. Well, the best we ever got was in 2003 when we reached 45%. And the line graph on the right just shows you since 1996, we've always been below that 45% mark. And that red dotted line is the Healthy People 2020 objective. With Healthy People 2030, and I'll talk more about Healthy People 2030 in a few minutes, we've lowered our objective now to 45%. Since we reached it once, we hope that in the next 10 years, we can do that again. But the biggest issue is, again, more than half of America cannot access or does not access dental care across the country each year. In rural America, we see this as a bigger problem even. And I'll talk in just a second about all the dental deserts in rural America. But we have 9.5% less access to dental care in rural America. Children are 5% less likely to receive preventive services. Adults are 7% more likely to be missing teeth because of not getting preventive services or early intervention, and are 4% more likely in rural America to have complete edentulism. And older adults, seniors, are less likely to access care as well. This map here shows these dental deserts. So shaded gray or purplish gray are all the designated dental health professional shortage areas, or HPSAs. And just for reference, most of Nebraska, if they use the national methodology, most of Nebraska also would be shaded. It's just they use a different methodology there. But you could see, if you just look at this, you can almost point out where the metropolitan areas are. So most of these gray shaded areas, these counties, are rural America. And it affects, there are about 60 million people living in these almost 6,500 designated dental HPSAs. Now, I want to also make a point that just because we're talking about rural America doesn't mean that there are people in metropolitan area, that all people in metropolitan areas have equal access to care too. We know that's not true. There are dental deserts within metropolitan areas, especially in minority populations. HRSA, the Health Resources and Services Administration, estimates that if we were to adequately address these dental HPSAs and place dental practitioners across all of these HPSAs, it would take more than 10,000 practitioners to just fill the need, the existing need that Americans have to access dental care. As a result, what we see is that in certain populations, we see a disproportionate burden of dental disease. And so the National Health and Nutrition Examination Survey, that's where these data come from. And if you look at Black non-Hispanic Americans and Mexican Americans and compare them to white non-Hispanic Americans, what you'll see is that across different disease conditions and across the lifespan, starting at 2 to 5 years of age, all the way up to over 65, minority populations have 2 to 3 times the prevalence of disease that white non-Hispanic Americans have. Then if you look at the bottom 2 rows and compare those living at or below 200% of the federal poverty level, that's what FPL is, and that the FPL is currently around $25,000 for a family of 4, you'll see that they also suffer disproportionately from dental disease compared to the middle class, those that are at or above 200% of the federal poverty level. So back in 2000, and I'll talk more about the Surgeon General's report in a few minutes, but One of the goals of the first Surgeon General's report was to eliminate oral health disparities that certain populations have. And as I'm showing you here, we're far from doing that. In addition, if we look at older adults and look at the changes in functional dentitions, that's people that have 21 or more teeth that are over the age of 65, what you'll see is that the poor and the non-poor over the last 2 or 3 decades have had substantial improvement in increasing the number of teeth that they retain. So if you look from 1988 to 94, you'll see that 16.7% of the poor had a functional dentition. 30 years later, that's 25.5%. The non-poor also, it went from 38.3 to 67. So both groups had substantial increases in the number of people with a functional dentition. But the disparity, which I highlighted in yellow, has significantly increased. So the non-poor have benefited much more than the poor, and that disparity, the difference between the two groups, has more than doubled over the last 30 years. So when we look at disparities, let's think about what the barriers are. Obviously, the social determinants of health, and I'll talk about that in the next slide, is a major barrier to improving access to care and delivery of dental services across the country, especially to vulnerable populations. But there's also an oral health literacy component, how well our patients understand and can be equal partners in their oral health care, the cost of oral health care, the cost of dental education, which drives where graduating dental students practice, and other workforce issues as well. So with regard to social determinants of health, one thing that we do in dentistry is we often wonder why our patients break appointments. And we often believe that, it's the patient's behaviors and things like that. There are a lot of things that come into play when it comes to compliance, when it comes to oral health literacy and so forth. So there are these big social determinants like how they were educated, politics, the social structure, social norms, the public policies that drive access to care and so forth. There's family determinants such as the culture they were brought up in, their family structure, their family health status, their socioeconomic status, things like that. And then there are individual determinants like their other behavioral issues like smoking, diabetes, stress, their oral hygiene, all of that. So all of these things combined really have an impact on oral diseases. I mentioned healthcare expenditures. Well, over the last 2 decades, healthcare expenditures have almost doubled from per capita expenses of $232 back in 1990 to $413 in 2018. And overall, adjusting for inflation, we've gone from about $60 billion in the oral healthcare expenditures in 1990 to $120 billion today. And then the American Dental Association did a survey, the Health Policy Institute, and they asked people if they did not go, which of the following services would they forego because of cost? And the vast majority would forego dental care, 9.5%, before they would forego medical care, eyeglasses, mental health, or prescription drugs. So in essence, many people still view oral health and dentistry as a luxury. Globally, we see this as well. The U.S. leads all of the other countries in the proportion of people that skip a dental checkup because of cost. Even though we have really, compared to other countries, and it's on the right, that map, we have a very low prevalence of disease. That's shaded in yellow. With you see the dark red, maroon, those are the countries that have the highest prevalence of all dental diseases, oropharyngeal cancer, dental caries, periodontal disease, etc. I mentioned cost of dental education. According to the American Dental Education Association, or ADEA, the average educational debt for the class of 2019 was $292,169. And about 4 out of 10 had loans or debt in excess of $300,000. Now, if you go back to the dental deserts slide, you can see that with this type of debt, which is estimated to be over $700,000 once they pay it back over a 25-year period, that this really drives many new dental graduates out of going back to rural areas, often their hometowns, and instead working in the more lucrative metropolitan markets. And, one thing is we have greatly increased the number of dentists. We've had a 22% increase over the last 2 decades. And this is because of pre-COVID, of course, fewer dentists retiring and dental schools churning out more dentists. But if you actually look at that number a little closer and look at based on population growth, we've actually had a much more modest 6% increase in the number of dentists in the last 20 years. And we also know that just like the dental deserts slide, the number of dentists per capita varies greatly state to state. New Jersey has the highest number of dentists per capita at 81.52, while Arkansas and many of the other southern states are like this as well, has the lowest at 40.93. Another issue I just want to briefly mention over the next couple of slides is the aging population. Over the next 20 to 30 years, what we're going to see is an enormous growth of people over the age of 65. And in fact, from 2000 to 2030, we'll see a doubling of the population of Americans over the age of 65, from about 35 million to 71 million. And if you look at our current population of adults over the age of 65, which is 54 million, that is enough to circle the globe at the equator 2 times. Or if you put them all in the states, that number is equal to the population of the 25 least populous states. So you've heard a lot about improving access to care and delivery of dental services to adults over the age of 65. And this is the reason that this is such an issue right now. And in fact, if you look at the data suggests that in 2035, we will have more adults over the age of 65 than youth and children under the age of 18 for the first time in the history of the U.S. And so if you compare the 2 groups and think about all of the services that we provide to children and youth under the age of 18, we have a lot to learn, a lot to do to improve the oral health and the delivery of dental services to adults over the age of 65 in the very near future. Okay, so at this point, I want to switch gears and talk about COVID-19. And I don't know how long this video will stay online. Hopefully, in a few months, we won't be talking about this subject anymore. But we all know that back in March, the White House Coronavirus Task Force, the response coordinator, Dr. Deborah Birx, recommend that hospitals and dentists cancel all elective surgeries over the next 2 weeks to free up hospital beds and space. And then this was followed up by guidance from CMS, the Centers for Medicare and Medicaid Services, from the Surgeon General, from the CDC, and so forth. And pretty much in mid-March, dental practices across the U.S. shut down elective care. One of the initial concerns we have, and I guess it still is a concern now that we've seen a new surge, is that there's a substantial number of Americans that go to emergency rooms to receive their oral health care or receive prescriptions for pain management or infections. And in fact, in 2009, and this is the latest data I have from the Agency for Healthcare Research and Quality, you will see that about 70% of those reporting to emergency departments, EDs, with dental conditions, either were uninsured or underinsured with Medicaid. So with COVID, what we saw was many emergency departments were really filled with COVID patients. And so the question was, where did all these people with oral health problems go and especially during the first few months of the pandemic? We also saw a dramatic decrease in the number of Medicaid children's dental services. So if you look at this graph, you'll see the top three lines, those are the number of dental services per month for children receiving Medicaid, number of dental services. And you'll see that on average, there's somewhere between 3.5 and 4 million dental services for Medicaid children dental services each month. But when the pandemic started and dental services shut down, you can see that bottom line that it dropped down to next to nothing in April. Now, there has been a resurgent number, and we're awaiting new numbers from the Centers for Medicaid and Medicare and Medicaid Services. So there has been a rebound, but it has had a significant impact on dental services for some of the most vulnerable children in the U.S. Now, the next three slides are from the ADA's Health Policy Institute, and they've done a remarkable job in surveying dentists and doing consumer confidence indexes and things like that. So this one is from back in early November, but it basically shows that about 38%, less than half of dental practices across the U.S., and this is primarily private practices, are operating at a level at or above their pre-COVID levels. So even though dental practices have reopened because of implementation of new infection control protocols, and perhaps some patients not going back to the dentist immediately, practices haven't fully rebounded across the country. In addition, we know that personal protective equipment has been a lingering problem for all healthcare professionals throughout this pandemic. And this graph from the ADA HPI again shows that there's been a great improvement in the number of practices that have more than a 2-week supply of masks and face shields, gowns, and so forth. And you can see that in the green and dark green. But there's still some practices that have less than a week's supply of these critical items that are needed to carry out delivery of dental services. And those are represented in the orange and the red. So we still have a lot to do to address these supply chain issues. And now that we've had another recent surge with COVID, we'll see that the strain on the supply chain will continue until we reach that herd immunity. I mentioned the consumer confidence. Most Americans have said that they are willing to go back to the dentist. There's 60% that said that they're ready to go. There's 23% that have said they have gone back to the dentist. There's an additional 5% or so that need just a little extra assurance that they should go back. But there is a little part of America, 12%, that says that they're really not comfortable until there is an approved vaccine. Well, now we know that there is an approved vaccine, but I think that, you know, there is a segment that wants to see that herd immunity and make sure that they're vaccinated and their dental staffs are vaccinated before they return to the dentist. And we see that happening already across America in different states. The CDC, Centers for Disease Control and Prevention Division of Oral Health, has issued recommendations for infection control in dental settings. They've issued guidances 2 or 3 times, starting back in May, and then again updated in August. And most recently, they gave recommendations, some interim guidance for restarting school-based sealant programs. And you can go to CDC, go to their website, and I listed it down the bottom, and it has links to all of the different guidance that the CDC has provided. But here are some of the key things, and that is we all recognize as oral health professionals that dental settings are unique in the way we're designed, in the way we deliver care, the frequent use of aerosol generating procedures, all of those types of things. And so the CDC has these suggestions on how we should recognize symptoms, how we should pre-screen patients, and so forth. So if you have not read those recently, they are updated from time to time. So I encourage you to read those. Now, I'm going to talk about vaccinations in a minute, but remember, even after you're vaccinated, you should still practice the 3 W's until we reach herd immunity. And those 3 W's are wear a mask, and that is wear a mask. If you're going to the grocery store, wear a mask. Wash, or if you're going anywhere, out in public where there is an expectation you'll run into someone, wash your hands. Wash your hands for 20 to 30 seconds. You follow the CDC guidance on hand hygiene. And watch your distance. Maintain a distance of 6 feet. And again, this is pre-vaccination and post-vaccination until we reach that critical herd immunity level. There are a lot of opportunities, a lot of things we've learned from this pandemic, things like teledentistry, which we had flirted with a little bit before COVID, and many of you have used teledentistry to screen patients. Our specialists have used it to provide guidance to general dentists. So we'll see more in the future on how we can better utilize teledentistry. We've also seen more integration of oral health and overall health, more medical dental integration. And, you know, we can seize that moment and use it to do better in educating about influenza, HPV, referring patients to primary care providers, doing point of care testing, things like that. We've also seen expansion of alternative dental workforce models. And I don't want to talk about all the different models out there, but there are some alternative models that have been shown to greatly increase access to care, especially in vulnerable populations. And then we've also seen, and we should continue to see, what strategies to improve delivery of care and mitigate or minimize aerosol generating procedures. Things like minimally invasive dentistry, interim therapeutic restorations, and so forth. You have probably heard much about vaccine hesitancy. So I borrowed this from the Kellogg Foundation. And this was actually done before the vaccine was given the emergency use authorization. And you can see that minority populations, especially Black, non-Hispanic Americans and Hispanics, had higher hesitancy than white non-Hispanic Americans in getting the vaccine. Now, things are greatly improving, but I think as oral health professionals, we should be talking to our patients about the vaccine. We should be talking especially to minority populations and reassuring them of the safety of the vaccine. So this is late breaking news. There are now at least 5 states. Now, this information comes from the American Association of Dental Boards and some other sources as well. But this is as of this morning, we now have at least 5 states that have authorized dentists to administer the COVID-19 vaccine, either the Pfizer or the Moderna. And that's Arkansas, California, Massachusetts, Oklahoma, and Oregon. And there are 9 states that are considering that. There may be more than this. So if you have updated information, please let me know. We're constantly updating this. We also have seen states that have allowed dentists to administer the influenza vaccine. And again, we have 5 states, Illinois, Minnesota, Oklahoma, Oregon, West Virginia, that allow it. And we have 7 states that are considering it. Now, thus far, the priority seems to be on allowing dentists to administer the COVID vaccine. But, we should also think that if we're going to administer vaccines in the future in some of our states, the influenza vaccine also makes a lot of sense. There also has been a big push across the country to allow dentists to perform or order the COVID-19 testing. And again, this is from the American Association of Dental Boards. 8 states are allowing dentists to order or actually perform the test in their office: Arizona, Florida, Iowa, Maryland, Minnesota, Oklahoma, Oregon, West Virginia. 7 others at least are considering it as well. And I mentioned earlier when we were talking about teledentistry about educating patients about HPV vaccination. And so I know we're talking about COVID, but I don't want to lose sight of the fact that HPV-attributed oropharyngeal cancer is now the #1 HPV-attributed cancer. And we need to remember that. And that means that I think oral health professionals have a role in HPV vaccination. Now, in some states like Oregon, that might include administration of the HPV vaccine, Gardasil 9. Or in other states, it may mean just educating patients about the need to get the HPV vaccine and referring them to a pharmacy or a medical provider that can actually administer it. And remember that Gardasil 9 has now been approved up to age 45. So ages 9 all the way up to 45 should be getting the HPV vaccine. All right, so next I want to talk about the Surgeon General's report. This is a picture of the first ever Surgeon General's report, which was issued in 2000 by then Surgeon General Vice Admiral David Satcher. And like all Surgeon General reports, there have been about 63, I believe. They're all available at surgeongeneral.gov. Out of all the Surgeon General reports, most of them have been on smoking. And in fact, our current Surgeon General, back before the pandemic, back in January 2020, a year ago, I believe released a Surgeon General's report on tobacco cessation, which was the first such report on tobacco cessation in over 30 years. But there's only been one report on oral health. And so now we're working on the second ever Surgeon General's report on oral health. That first report had as its major message that oral health means much more than just healthy teeth. And it truly is integral to the overall health and well-being of all Americans. It was followed up. I mentioned the goal of eliminating health disparities, but it was followed up in 2003 with some specific actions that Americans and health professionals, community members, leaders could take to improve the oral health of our country. And those were outline goals to promote oral health, to improve quality of life, and like I mentioned before, to eliminate oral health disparities, but unfortunately, those still persist. So this second ever report, which hopefully will be out sometime in 2021, has the following sections, and I'm not going to read these, but it's important to note that it's not going to just be about oral health. We're going to look at the relationships between oral health and other diseases, the effects of addiction and mental health on oral health, and things like that. We'll also look at the future, emerging technologies and promising science that will transform oral health in the future as well. So if you want more information about the second ever Surgeon General's report on oral health, we had a listening session that invited many external stakeholders. There have also been other information slide sets and so forth. Here's some links to that information. It is expected that this report will emphasize that poor oral health continues to be a significant public health issue, that it's an important issue throughout the lifespan. And as I mentioned, things like the aging population, access to care, the cost of dental education, and so forth, there are many issues that affect oral health at a population level. It also will outline a vision for the future in terms of policy and research, and educate, encourage, and call on all Americans to take action. So finally, what I'd like to talk about is Healthy People 2030. And I mentioned before that Healthy People is a set of national priorities that are set every decade. And what I'm going to do is go through all 11 of the Healthy People oral health objectives, just to give you some idea of what they are. You can also go to healthypeople.gov to get more information. I'll reference that again at the end. But our first oral health objective is to reduce the proportion of children and adolescents with lifetime decay or caries experience for the ages of 3 to 19. Our baseline is 48.4%. By the end of the decade, we want to reduce that to 42.9%. Oral health objective number 2 is to reduce the proportion of children and adolescents with active and untreated decay. And again, 3 to 19 years of age. Baseline is 13.4%. And by the end of the decade, we want to reduce that to 10.2%. In looking at adult oral health objective number 3 is to reduce the proportion of adults between the ages of 20 and 74 years of age with active or untreated tooth decay from 22.8% to 17.3%. Oral health objective 4 is to reduce the proportion of older adults over the age of 75 with untreated root surface decay from 29.1 to 20.1%. Oral health objective 5 is to reduce the proportion of adults 45 and over who have lost all of their teeth, completed dentalism, from 7.9% to 5.4%. Oral health objective 6, again, we're still on oral health for adults, is to reduce the proportion of adults with moderate and severe periodontitis, 45 and over, from 44.5 to 39.3%. And finally, the last oral health adult objective is to increase the proportion of oral and pharyngeal cancers detected at the earliest stage. And we want that to go from 29.5 to 34.2% over the decade. There are also some measures that address access to preventive care, including oral health objective 8, which is to increase the proportion of children, adolescents, and adults who use the oral health system. And this goes back to that access to dental care slide that I showed you. Again, our current number is 43.3%, the highest we've ever been, and our target for 2030 is 45.0%. And I also want to point out that the federal government also uses something called leading health indicators to put the top national health priorities out there. And oral health this past decade for Healthy People 2020, for the first time, oral health was a leading health indicator. And for 2030, oral health is once again a leading health indicator, one of 12 topic areas, which is very significant in that it's such a high priority for overall health. And the specific objective is this oral health objective 8, to increase access to care within our healthcare delivery system. Oral health objective 9 is to increase the proportion of low-income youth who have a preventive visit from 78.8% to 82.7%. And then there are 2 objectives. The last 2 measurable objectives are specific to interventions. Oral health objective 10 is to increase the proportion of children and adolescents who receive dental sealants on one or more of their primary or permanent molar teeth. And the baseline is 37.0%, and we're trying to achieve 42.5%. And the one note that I just want to say is that you have to remember that there have been policy statements by the American Academy of Pediatric Dentistry and the American Dental Association to place dental sealants on primary molars when indicated. So I just want to, this isn't just primary molars, but a lot of dentists are still hesitant to do primary molar sealants. And then oral health objective number 11 is to increase the proportion of persons served by community water systems that are optimally fluoridated. And we want to go from 72.8% of Americans that have access to fluoridated water in community water systems to 77.1%. There are also, if you go to healthypeople.gov and you click on search by condition and click on oral condition, what you'll see is not just those 11 specific oral health objectives, but you'll see these as well. We have a developmental objective, which means it's we're just trying to look at it this decade, and maybe it will be a reportable measure the next decade, but it's to increase the number of states and the district that have a surveillance system, an oral and craniofacial surveillance system. And then there are 3 other non-specific oral health objectives that are under that oral conditions. And one is to increase the proportion of people with dental insurance. One is to reduce the proportion of people who can't get the dental care they need when they need it. And one is to reduce consumption of added sugars age 2 and over, because we know that contributes to caries. So the question everybody asks is, okay, so what? How can I use this Healthy People information in my practice? How can I, help improve population health? And I'll go over that in the next couple of slides. Number 1, if you manage a program, if you're in private practice, you can do things. If you manage a program, you can do things as well. So you identify priority populations. You can learn more about which populations. I showed you some of the disparity slides, but you can prioritize care for some of these vulnerable populations. You can set your own targets as well. Whether you're in a small private practice or a large practice, you can talk about within your patient population, how can you decrease caries experience, and how can you measure that as well? You can find practical tools. You can go to healthypeople.gov again and look for some practical tools. You can do things to educate patients about dental caries. You can get information from that Healthy People website to improve oral health literacy. And then you can also use data that we provide at the national level to check periodically on how we're all doing. Here's some links that hopefully this slide set will be made available to you, so you can use these links to learn more about Healthy People. And again, you can go to this Tools for Action to get some specific ideas on what you can do in your practice to improve oral health. So with that, I would just like to once again thank all of you. I know this is we've covered a lot of ground today, and I didn't really do a deep dive into any of those issues, but I hope you got something out of this. And I've listed my contact information. Feel free to email me at uspHscdo@ihs.gov if you have any questions or if you have suggestions on what we can do at a national level to improve oral health. So with that, I'd like to turn it back over to Dr. Farang, and thank you all very much. Thank you for what you do each and every day to improve the oral health of all Americans. Thank you.
That was the most excellent presentation ever given on on dentistry and sensory. It was an amazing presentation. Do you have any time for any questions? I know you're the busiest man in dentistry.
Certainly, I've got time.
You got time? First of all, about a quarter of our viewers are still in dental kindergarten school. They haven't even got out yet, and a lot of them are considering a career in public health. And I noticed on Dental Town today, someone, a dentist said, recruiting for dentist position in tribally run Indian health clinic in Northern California. Hi, I've been employed with the United Indian Health Service for almost 3 years after leaving my private practice. And he goes on to talk about the compensation for dentists is very competitive. And they offer great benefits, paid vacation, insurance, paid holidays, paid CE, travel experiences. UIHS dentists are eligible for the IHS student loan repayment plan of $40,000. For 2 years, 50,000, it goes on and on. What would you tell a young kid in dental school who's considering a career in public health?
Well, I mean, first of all, whoever that is at United Indian Health Services, thank you. You've done a great job helping me recruit. I am actually my day job. I work for the Indian Health Service. The Indian Health Service does, in fact, have a loan repayment program that is available to anyone that applies for any dentist that applies for an IHS, tribal, or the IHS also funds or has some urban dental programs as well. So there is also another loan repayment program, the National Health Service Corps. As long as the dentist goes to a National Health Service Corps site, it has to have a certain score. And again, that goes back to those health professional shortage area designations. But so there are a lot of loan repayment opportunities. In addition, some states offer some great loan repayment options or loan forgiveness options as well. So what I would say as far as about public health in general is when I was in dental school trains you to become a private practice dentist. And I began as an associate or independent contractor, then associate dentist, then a sole proprietor. And while I was in private practice, I kind of had this yearning to do something for the greater good. I mean, I thought I was making a difference with my patients, but I wanted to do more for a larger population. And that's what public health is all about. It's that dentist out at UIHS, United Indian Health Services in California, isn't making a difference just for the patients that happen to come into that clinic on a given day. But that dentist is out there trying to look at reducing dental disease in all of the Native Americans he or she serves. And that's what population health is all about. It's about serving the greater good for our entire population versus the individual patient.
That dentist was Dr. Kirk Peterson, D.M.D, F.I.C.D, dental director out in Arcata, California.
Wonderful.
And I'll email you. I'll email you both. Tell you the kind of words. And then last but not least, Arizona is it's like 25% Indian reservation. Are they doing okay? I know they got hit pretty hard up north.
You're talking about in regards to COVID?
Yeah, yes, COVID.
So, yeah, you can get the latest numbers on COVID for the Indian Health Service at ihs.gov, ihs.gov. But yeah, the Navajo Nation, which covers the Four Corners area, has been hit pretty hard compared to other populations. So yeah, in the entire desert Southwest, I think has higher numbers as well. So yeah, it's pretty rough in American Indians and Alaska Natives, that pandemic. So
Yeah, that's been really tough. My gosh, I just am so thankful that you took the time to come on the show today. I know you're so busy, wall to wall pack meetings, but thank you for this outstanding presentation. Thank you for your service to the country. And my final question is, in dental school, did you ever, in your wildest dream, think you'd be serving your position during a pandemic?
absolutely not. All I wanted when I was in dental school was to get out of dental school. Once I got out of dental school, all I want to do was to serve others. And that's one thing. I'm no different from anyone that is listening to this. All of us got into dentistry to serve other people and to do our very best. And, you know, whether you're a chief dental officer, whether you're a dentist in private practice, whether you're a dentist in public health, the work that you do each and every day is making a difference in people's lives. So again, I applaud all of you. Y'all are the ones down in the trenches doing the work each and every day. So you're the true heroes with before and after the pandemic. So thank you all as well.
And thank you. And on that note, thank you so much. And I hope you have a fantastic rest of the day.
Thank you. You as well.